Hi, I'm Dr. Warren McKaylee. I'm a peripheral nerve surgeon, and we're going to talk a little bit about phantom limb pain. Phantom limb pain happens when a body part is cut and someone continues to feel sensation, commonly associated with lower extremity amputations. The rates of chronic phantom limb pain, and I'm going to loop in post-amputation pain, so like neuromatous pain, because that's how the studies were done, it's about 87%. When the nerve is cut, patients will end up having the sensation. Sometimes, actually the biggest complaint that I've heard is when patients have itching in the limb that's no longer there, and you just can't scratch it because it's not there. Dr. Damanian over at Northwestern, he had developed a surgery called a targeted muscle reinnervation, and the reason he did this, where he was connecting a sensory nerve to a motor nerve, that was for better myomechanical prosthetic control. While that did work and has really changed the world of prosthetics, what happened is that about 80% of these patients, their phantom limb pain went away. And that really kind of started a new paradigm shift in how we treat neuromas in general. If a patient requires an amputation and I know in advance, sometimes I'll offer to do the complete amputation myself, or sometimes the vascular surgeon or the orthopedic surgeon will call me. They will start the amputation and then I'll usually finish it. I will make sure that when I do that, I address all of the nerves in that limb. So for example, in a lower extremity, you will usually have the deep perineal nerve, superficial perineal nerve, the saphenous nerve, the sural nerve, and the tibial nerve. The best approach is a preventative approach. If I get there during the initial amputation, whether it's a foot, an arm, a toe, whatever the case may be, I will do the nerve reconstruction at that time. However, for many patients, it's not an option. Taking care of patients well past when their amputation has happened, essentially it can be done in one of two ways. Either I can open up the stump if they need a larger revision for one reason and find the nerves and treat it like a primary. So I'll resect the neuromas at the ends, and then I will do a TMR or an RPNI or a VRPNI of each of those nerves. These are all reconstructive techniques that I have videos about. Or sometimes I could also do a popliteal approach, so if it's, let's say, in the knee, or go to a more proximal approach, I guess, if we're going to talk about another part of the body, and we could do the sensory nerve to motor nerves there. Oftentimes that will not interfere with their prosthetic use at all because the incision is nowhere near where their prosthetic was seated. The patients go home the same day. They do really well. They don't require any narcotics when they go home. Usually it's Tylenol and Advil. Again, I tell patients that it could take up to 3 months to notice the difference, but oftentimes they'll notice it on day one. And while they're in some sort of discomfort, usually from the surgery, it's a very different discomfort, and they're usually feeling very positive about the experience because they notice that it's different. So that newfound hope kind of kicks in right away.